CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
All right. Hello, everybody. It's my pleasure today to introduce Dr. Roxana Geoffrion. I'd like to start just to say we'd like to begin by acknowledging that the land on which we gather is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I've had the pleasure of working with Roxana for some time. She's an associate professor at University of British Columbia and has a clinical practice as a urogynecologist at the Center for Pelvic Floor at St. Paul's Hospital in Vancouver. She completed her medical degree at McGill University in 2001 and her residency in Obstetrics and Gynaecology at the University of Ottawa in 2006. She then pursued subspecialty fellowship training in female pelvic medicine and reconstructive surgery, as well as a faculty teaching certificate at the University of Calgary. She's the director of the UBC Advanced Training Program in female pelvic medicine and reconstructive surgery. She mentors various trainees and also her peers in the performance of minimally invasive pelvic floor surgeries. In addition, she has a strong research interest in competency-based surgical education, patient education, and knowledge translation in the area of pelvic floor health and prevention of disease, as well as surgical outcomes and sexual health of women with pelvic floor disorders. Dr. Geoffrion regularly contributes to national guidelines for best practice in her subspecialty field to the Society of Obstetrician Gynecologists of Canada. So with no further ado, I'll turn it over to Bill.
Thank you very much, Joel, for that kind introduction. And can you all hear me well? I know you can't see me because I'm kind of short, but I'll try to speak a little bit louder. Thanks for sharing your lunch hour with me today. As Joel said, I'm a pelvic reconstructive surgeon, and I also do research on the side with the help of many people who have graciously given me their time. So today I want to take you on a journey that happens to be mine, essentially talking about surgical innovation and in the particular area of pelvic organ prolapse. So just show of hands amongst you, who knows, other than Nikki here, what pelvic organ prolapse actually is? All right, great. So you guys are going to be, I'm looking forward to your research suggestions, but hopefully you'll learn a little bit about the clinical aspects of pelvic organ prolapse. So prolapse is one of those conditions of women's health that's rarely talked about by both surgeons, physicians, and also women themselves who find it somewhat embarrassing and isolating. It's also been called the silent epidemic. It happens to a lot of women as they age. It's essentially a hernia that happens through the vaginal opening because of weakness in tissues and ligaments. Main risk factors include childbirth, lots of children born vaginally, childbirth trauma, aging, obesity, constipation, and other conditions that cause women to push against their pelvic floor and cause weakness in that area. So using the example of this particular clinical condition, we're also going to examine innovation in surgery and how to evaluate outcomes, and also using the example of particularly synthetic mesh for prolapse, which has been a bit of a controversy lately. I was going to follow an evidence-based approach to how to develop a new surgical procedure or any innovation in surgery, really. I have no disclosures. And so this is the only medical clinical image I'm going to put up, so please don't leave the room quite yet. But essentially, I'm going to try to point here. This is a normal pelvis viewed from the side with the uterus sitting comfortably in the lower pelvis, and with the vagina being a canal below it, the bladder in front, the bowel at the back. And what happens with prolapse is essentially tissues are herniating through the vaginal opening and the uterus comes down. And so in this particular case here, you can see the cervix at the level of the vaginal opening. And in this particular case here, you can see inside out prolapse. So as bad as it gets, essentially, where the uterus is exteriorized, and so are parts of the bladder, the rectum, and some small bowel are essentially hanging out outside the body. And I just want you to take a moment to think about what this woman is going through with her activities of daily living, how she walks, how she sits, how she tries to be, intimate with her partner, and all the social isolation and problems that can follow from this condition. And these pelvic floor disorders, including prolapse, which is at the top there, don't really come alone. Oftentimes when your bladder is outside your body, well, you'll have perhaps some urinary incontinence or voiding difficulties. Definitely some sexual dysfunction, occasionally pain, infections, fecal incontinence, fistula, and of course the psychosocial aspect of it all with body image issues and social isolation. So pelvic floor disorders often coexist. When we fix prolapse, we also have to address the other issues that can happen concurrently and try to fix them at the same time. Fun facts about prolapse. Routine gynecologic examination detects prolapse in 1 out of 2 patients. So what does that mean? Well, let's say a woman has had 1 or 2 childbirths and then presents for routine gynecologic care. Her gynecologist may see some prolapse there. 1 out of 2 patients, 1 out of 2 aging women have some prolapse. Does that mean that it all needs to be fixed? Absolutely not. It's just some of it is normal and asymptomatic. Prolapse is really only symptomatic in 3 to 6% of women if you take a cross-section of the population. And so the first question we ask when we try to fix prolapse, either with conservative or surgical treatments, is, does this patient have bothersome prolapse symptoms? And really the most reliable symptom that we can take away or help them with is the symptom of bulge or protrusion. And this is really important because other things can masquerade as prolapse discomfort, perhaps pelvic pain, and that's important to note. And that's because most of our surgeries that we do are essentially for improvement of quality of life. Not everybody looks like the first patient I showed you there with a very large prolapse. And so we need to understand women's goals as we perform these surgeries. That being said, if you look at studies looking at the incidence of prolapse surgery, so this is lifetime risk of first-time prolapse surgery, by age 80, women have about a 1 in 5 chance of having an operation for pelvic organ prolapse, which tells you perhaps that conservative treatments are not necessarily fantastic, that surgeries aren't fantastic either, and that perhaps women are looking for solutions. So we did a small study at our center where we looked at women's goals with pelvic reconstructive surgery. So it's 60 women who told us what they wanted to achieve with our surgeries. Most of them wanted to reduce bulge and protrusion symptoms. Half of them wanted to improve urinary symptoms, improve activities in social life, reduce discomfort and pain. A third of them wanted to improve intimacy and wanted to improve their general health, also, preferably in a durable way. These are pictures available online from our International Gynaecologic Association of our 2 standard procedures that we can perform through a vaginal approach to fix prolapse of the top of the vagina, so the uterus, like you saw in those pictures that I showed earlier. And you can see here, perhaps I can try to point for you, but here there's a picture of a pelvic floor with the muscles that, perhaps you've heard of Kegel's exercises. These are the muscles that women squeeze to perform Kegel's exercises. You've got the vagina, and then the vagina all of a sudden is tacked up or suspended to these ligaments near the tailbone called the sacrospinous ligaments. And that's the oldest type of vaginal suspension used. It's very routine, gold standard, I would say, in Canada. And then here you've got a completely different type of suspension where the uterosacral ligaments are used. So essentially the idea of trying to use the ligaments in the pelvis and use sutures to suspend the vagina so that it doesn't come down again. Well, unfortunately, as you can imagine, the larger the prolapse is, the less these suture suspensions actually hold. So it would be nice if we can tell a woman who comes in and has this procedure that their surgical success is 100%. That would be great, but it's not the case. So women often come back with prolapse recurrence. So they've had this big surgery, it lasted 4 hours, they recovered from it over 6 weeks, and then they went on with their lives. And we dealt with broken tissues that we tried to attach, tack up the ligaments, and it didn't work. So women come back a year, 2 years later, 5 years later, the prolapse is back. I always say it's not like the appendix. You've had an appendicitis, you had your appendix out, you're never going to hear problems about your appendix again. This is prolapse, it may come back. And so we're always trying to improve on our suture suspensions and our surgical treatments to make them more durable and less complicated and better for patients. So with that in mind, surgeons extrapolated in the past 10, 15 years and applied this thing called synthetic mesh to prolapse. So instead of synthetic sutures, the same material was used to weave a large sheath of actually varying dimensions. That's just one example of a vaginal mesh kit used to fix prolapse. So you can see the size of this versus 2 or 3 sutures. So we're thinking the more material we're using, the better the durability will be. And so why use mesh? Well, prolapse is extremely common. Surgical outcomes of suture suspensions are far from perfect. And we know that some meshes have had superior success as sutures. So how did this all start? Well, you may have heard of abdominal hernias and how introducing synthetic mesh for abdominal hernias was actually working better than sutures. And so based on that model, surgeons in pelvic reconstructive surgery started using these meshes to put behind the vagina to elevate things. And I'm going to just change for a moment to this other type of vaginal mesh called tension-free vaginal tape, which was introduced in the early 1990s for stress urinary incontinence, which often comes with prolapse, so women leak urine with coughing and sneezing, also associated with the same sort of pressure risk factors as prolapse. And we know that the TVT is a very, very good procedure for stress incontinence. There's gold standard for it, and it was developed in the 1990s just before all these other meshes for prolapse were introduced. And this is what it looks like. So you've got a picture of the pelvis there, looking at the pubic symphysis in the front and the bony pelvis, and you've got the bladder and the urethra, and you've got a little sling here. So it's a material that's 11 millimeters in width and about 8 centimeters in length, and it sits like provides partial compression of the urethra so that when women cough and sneeze, there's almost like a little backstop there so they don't leak urine. Works very well. We know this is probably the best studied procedure in gynecology overall. Excellent complication profile, excellent durability. And so based on that, so next slide, this would be, it shows you essentially that the TVT was started in the early 1990s, and then people still wanted to improve on it, mainly because if you go back one, you can see that these little mesh arms are sitting very close to the bladder, very close to perhaps the bowel that's behind here. So people were trying to improve on things, staying farther away from the bladder and the bowel. And so they came up with this next thing called the transobturator tape. You don't have to remember all the names, but essentially it was a different sling that was passing through groin muscles. But it was very different because it was passing through groin muscles, and it started producing groin pain for women. So the incidence of pain post-TVT, almost nil. Incidence of pain with TOT, 12% groin pain. And so if this is a younger sort of active woman trying to, I don't know, run, do athletic activities, groin pain is actually a fairly debilitating thing. And then after that, they tried to extrapolate to say, well, how about mini slings? We're going to put even less mesh material and perhaps not pass it quite so close to muscles, and maybe that'll be better. Meanwhile, traditional slings made out of patients' own tissues sort of fell off the radar, both with research and in terms of interest, because the TVT was so good and we had these new kids on the block, why not experiment? So we don't really have much research on traditional slings in terms of efficacy and durability. And then the TVT still stands. So we know that on this model, TVT, which is a vaginally inserted synthetic mesh for incontinence, works much better than the older Birch procedure, which is an anti-incontinence procedure with sutures. And so this is just one example where, women with Birch 120 months later would have more reoperations than women with TVT. And of course, this study, which was great, 17 years follow-up of the TVT procedure for female stress incontinence, showing that 9 out of 10 women are still objectively continent, and almost the same number are subjectively cured or significantly improved. So excellent success rates for TVT, undeniably. However, This is what was happening in 2008. So remember, the TVT was early 1990s. In about 2008, the FDA, which is the regulatory body for implants in the U.S., started raising the alarm. Serious but rare complications associated with the use of mesh for prolapse and stress incontinence surgeries, with more than 1,000 adverse events reported. Of course, we don't have a denominator for this, and some adverse events were quite minor, and they were all lumped together between prolapse and stress incontinence. However, the FDA was watching this and recommended specialized training, vigilance about complications, as well as counseling patients about what to do with this, and you know, really long discussions about all the potential complications that can happen. Then that was updated in 2011, where the FDA came out and said complications associated with surgical mesh for transvaginal repair of prolapse, so this is only about prolapse, are not rare. It's not clear that transvaginal prolapse repairs with mesh is more effective than traditional non-mesh repair, by that meaning sutures, in all patients with prolapse. So perhaps certain patients with prolapse benefit more from sutures or mesh than others. So that sort of risk stratification wasn't there yet. And it may expose patients to greater risk. And then more adverse events were reported, 2008 to 2010, and then also coming out and saying that sacrocolpopexy, which is the abdominal mesh procedure, so not inserted vaginally, presents less risk, so not so much a problem. So perhaps it's not quite the mesh itself, but the way we place it. And at that point, they were considering reclassifying vaginal mesh from Class 2 to Class 3 devices. And Class 3 devices just mean more risk and need for stringent evaluation by companies when introduced as an implant. Finally, 2014, 2016, they made a clear distinction between stress incontinence and prolapse mesh, and the vaginal mesh used for prolapse repair was reclassified from Class 2 to 3, Class 2 being low to moderate and Class 3 being a high-risk device, meaning that the companies, so you know, in this field, it was mostly companies innovating with the help of minimal help from actual surgeons, would have to produce evidence that these devices would actually be safe and efficacious before introduction. Of course, that produced a media frenzy, you know, with lots of women coming out about complications that are life-altering, and a lot of general anxiety in the public at large about vaginal mesh, which became the new four-letter word, and the new bad four-letter word, I should say. And essentially, lawyers in the U.S. mainly got hold of women who had mesh implanted but weren't having any symptoms, and approached them telling them to have their mesh removed, because that was going to be a terrible thing. So they had their mesh removed without any symptoms, and then they had their prolapse and incontinence returned. So now the women are suing the lawyers who wanted them to sue in the first place, and it's just very chaotic. And of course, a lot of people are just getting out of this business altogether, and you can imagine what will happen, right? You know, women are going on with their conditions without help. Surgeons, many of them, I would say half or 75% of them, do not want to operate in this way anymore. And it completely kills surgical innovation, because many companies have gone bankrupt over these devices and procedures, and they really, it's just not sustainable. So this culminated in the FDA last notice, came out in April of 2019, this year, with strong words. FDA takes action to protect women's health and orders manufacturers of surgical mesh intended for transvaginal repair of prolapse to stop selling all devices. Meaning that, where does that leave us? Well, you know, does that mean that mesh is illegal? No, we use it. We use it for TVT, which is an excellent procedure. We use it for sacrocolpopexies, and perhaps we should use it for vaginal mesh, just like a TVT, but we just don't know how yet. And why are we still talking about this? Why not just use the older suture suspensions? Well, because, so this is probably the best conducted trial in urogynecology of a surgical trial, a randomized controlled trial, with yearly follow-up to 5 years. It's published in JAMA, and essentially randomized women to one of the two suspensions that I showed you in an earlier slide, so uterosacral ligament versus sacrospinous ligament, just essentially two different attachment points. And they looked at what the outcomes were, follow up to 5 years, and they had fantastic outcomes, composite outcomes with both objective measurement of prolapse recurrence, meaning looking at the prolapse, determining if it's back, and also asking women if they were, again, symptomatic from prolapse. They had standard procedures, so the hysterectomy was performed every time if the uterus was there. They had the same type of sutures used, and all of the collection of data was similar. And they showed that women had high objective recurrence. However, they had sustained symptomatic relief and low reoperation rates. So let me put that into perspective for you. This is a table, a graph from their study. It shows time in years on the x-axis and probability of surgical failure on the y-axis. And so you can see that at 5 years, about half of women only were very much better or much better. Half. That's just really poor as far as I'm concerned. Fewer reoperations, what does that mean? Well, so here I am, a woman who has quality of life issues. I'm going for an operation and then subjected to the rigors of a clinical trial over 5 years with yearly follow-ups. Do I really want, even if I was symptomatic again from my prolapse, would I want another reoperation immediately? Probably not. So is reoperation a good measure of success for these women? Probably not. So I would say that the fact that 50% of women only were very much better is actually not very good. So there's room for innovation. Now this is me at the center there. So we feel like that on a daily basis. We're stuck between the devil of complications and the deep sea of durability. We want to give these women a durable surgery that's going to fix their problem so that they don't have to come back in 2 years with symptoms again. And then we're surgeons, right? So I think of this every day of my life. If I'm always doing what I've always done, I'm always going to get exactly the same thing. And so I want to innovate, just like many, many surgical colleagues I have, and that's a very common theme in surgery. So what does that mean? What is innovation? Well, innovation means using a new or modified procedure different from accepted practice, different from standard of care in some way. It can be a small way or a large way, but we don't know the outcomes and it may entail risk. Historically, surgery, trial and error. So, surgeons were operating for limb amputations, gangrenous toes, war zones, removing large tumors that were life-threatening. But increasingly, surgery has become a place in medicine where we operate for improving quality of life of patients. And so in the past, surgery hasn't been held to a high standard for evaluation, for rigorous research. But now, increasingly, the bar is higher. And the other thing is that surgical innovation remains largely self-regulated. And what I mean by that is, well, take, for example, adult donor liver transplant. So at the beginnings of it, it was introduced, and there is no regulatory body. The FDA, Health Canada only intervene when it's about a medication or a device that's implanted or something like that. But when it's a procedure or an innovation on an old procedure, they don't really intervene. So between innovation and harm to the patient, there's, the sense of ethics of the surgeon, the surgical skill, and perhaps fear of medical legal consequences. But really, so what happened with introducing donor adult transplant was that initially there was a lot of morbidity to the donors. So until they introduced very standardized practice for care of donors for liver transplant, there was a lot of morbidity for the donor, which shouldn't have happened. And then there are other procedures, such as, for example, laparoscopic cholecystectomy. So removing gallbladders always used to be done through an open approach, so making a large incision. And nowadays, most surgeons will do laparoscopy, so a minimally invasive approach with small incisions in the abdomen to remove the gallbladder. And within 3-4 years of it being introduced as a minimally invasive innovation, it was taken up by most surgeons. Most surgeons got training and they started doing it. And luckily, it was a good procedure, but that's not necessarily the case for all procedures that we innovate with. What are the barriers to surgical evidence-based research? Well, there are some strong voices in this. Even surgeons, but even patients will have really strong opinions as to what they want, and it precludes randomization. The interventions we try to use are very complex with minor variations, and we're all trying to innovate all the time, so we have trouble adhering to a research protocol where procedures are standard. Surgeon blinding is, of course, impossible. You can't tell me, you have to tell me what I'm doing. You can't just blind me to it. And there are, you know, people like myself are a rare breed in surgery, so there are very few clinician scientists. We all go into surgery because we like to operate. We don't necessarily like to do research, or are not properly remunerated, or have other barriers like that. And so there are very, very few academic surgeons around that you will meet. So this is an example of diffusion curves for laparoscopic procedures. So again, going back to laparoscopic cholecystectomy, this is a graph showing you on the x-axis number of years since the introduction of the procedure, so up to 15 years. And then on the y-axis, you've got percentage of surgeons who will perform these cases laparoscopically, so not open. So doing laparoscopy is perceived as a better option because it's minimally invasive and people recover faster. So, however, if you can see on this graph here, laparoscopic cholecystectomy fares the best. This is the curve for laparoscopic cholecystectomy. 3 years after introduction, 60–70% of surgeons have adopted it and they're performing it happily and everything is going well. Well, take hysterectomy, which is blue squares down here. Well, 15 years later, only about 10% of gynecologic surgeons will perform laparoscopic hysterectomy. And there are other reasons for that, not just really, you know, perhaps some surgeons are better with performing vaginal hysterectomy. So in gynecology, there are other options to remove the uterus that are perhaps even better than laparoscopy. So there are many reasons for this, but what I wanted to point out with this graph is really laparoscopic cholecystectomy, great example. The first few years are when things need to be evaluated to see if this is a good procedure or not. So if somebody now wanted to perform a trial of laparoscopic versus open cholecystectomy, they wouldn't receive the funding and nobody would be interested in participating because laparoscopic cholecystectomy is the standard of care. And so you've got a limited amount of time when you can actually study this at the beginning and evaluate your innovation. This is what happened with transvaginal mesh. A lot of people adopted it at the beginning and then it completely fell off because it wasn't properly evaluated, and now it's really not available anymore because it was pulled off the market across the board. So how do we do this? How do we do this better? How do we make it better for our patients? There are, believe it or not, guidelines for doing surgical research and innovation. So there's this wonderful paper, a series of papers that were published in the Lancet, No Surgical Innovation Without Evaluation. They came out with recommendations for a framework to follow called IDEAL. And what does IDEAL stand for? Well, it stands for Idea, Development, Exploration, Assessment, and Long-Term Study. So if you were to come up with a small change on a procedure that you were doing, you would have to essentially go through these stages, which take a long time and require a lot of money, to actually show that your procedure is superior. Well, this is what the FDA is saying. It's not saying that vaginal mesh is illegal or we shouldn't use it, but it's saying that to support a favorable benefit-risk profile, the effectiveness of mesh for transvaginal repair of prolapse should be superior. So it has to be better, or else don't use it, to sutures at 36 months, so 3 years. And the safety outcomes for mesh for vaginal repair of prolapse should be comparable to native tissue repair. Of course, it's a different procedure. It's not going to be the same, but it should be comparable. So no new big bad things should happen to patients as you're using vaginal mesh. So this is the standard that we're held to now. Now, we know how to insert vaginal mesh. We know how to put in TVTs, which I talked to you about, the mesh for incontinence. It is also a vaginal mesh, same exact material. We know that we have to use large pore mesh. We know that we have to put it in very deep and away from fresh vaginal incisions to avoid exposures and erosions in the vagina. We know that we have to place it tension-free without pulling on ligaments and that causes pain. And ideally, we should recreate the normal anatomy of ligaments with synthetic material. We're also deeply familiar with the pelvic anatomy of this. We've all gone through cadaveric dissections where we know exactly where the ligaments are lying and what their relationships are to major structures and where it's actually safe to place these sutures. We have that knowledge. And so back in 2008, we came up with this idea to innovate on prolapse. And so this is in parallel to everything else that was happening with the development of vaginal mesh kits and so on. And so again, you've got on the left this procedure that is our standard, gold standard, tacking the vagina up to the sacrospinous ligaments with synthetic sutures. And then this is tensioned and it pulls the vagina off to one side. It's not anatomic and we're not recreating ligaments. So we wanted to make it better. Well, we said, why don't we have a little sling, just like the TVT, but for prolapse. So taking vaginal mesh arms, attaching, instead of pulling the vagina off to one side to tack it up to the sacrospinous ligaments. You can do it bilaterally as well, but that really stretches the top of the vagina too much, and again can cause pain. So, we were going to take these small mesh arms and attach them through the vagina to ligaments at the back of the vagina, same ligaments, sacrospinous ligaments, and that would essentially place the vagina in the center of the pelvis again, lift it up, and it would be done in a tension-free fashion. And this, as you can imagine, is a really deep place to put these mesh arms. And so very, very small risk of having the mesh come out to the surface of the vagina, unlike those larger meshes that were used in transvaginal mesh kits. So that was our idea and proof of concept back in 2008. We kind of came up with this. And this is what the mesh actually looks like. It's a very standard, this is just a drawing on a green towel in the operating room, essentially demonstrating the dimensions of this. So you've got the TVT, which is like a sling, but this is essentially two little arms. So this is actual mesh that's introduced in a patient, and it goes from the top of the vagina, links the top of the vagina like an arm to the sacrospinous ligament, very close to this bony structure called the ischial spine. And we know that these arms should be about 5 centimeters long and should essentially cover the vaginal vault. And because of the normal width of vaginal vault in women, we know that these mesh arms should be about 2 to 3 centimeters in width. And we have these nice smaller insertion devices because in parallel to surgical innovations, other companies also innovated on ways to place sutures deep in the pelvis, avoiding large dissections, avoiding too much blood loss. And so this is an example of one such insertion device called a Capio device, which we use for suture suspensions and for mesh repairs as well. And so how do we know these dimensions? Well, you're probably asking, how do we know? Well, we kind of know the difference, or the distance, I should say, between spines in women who've had children before. That's called a gynaecoid pelvis. And we've done some MRI studies. This is some part of that ideal development stage. So that's back in 2012, where we essentially took women with normal anatomy, and they had MRIs, and we looked at where the vault and the cervix, the top of the vagina and the cervix lie with respect to the spines in 3D in vivo anatomy, and then essentially try to recreate that with the length and width of the mesh arms and put our patients who have had this procedure through the MRI as well, and looked at how the mesh sits at 1 year after their surgery. Is it tensioned? Is it kinked? Is it changed? Is it migrated? And is it really still sitting in exactly the same place as a normal woman without prolapse would be? So we were trying to recreate normal anatomy, and it looked like we did. And then we had also in the exploration phase, we had a small clinical study which was looking essentially at our procedure, which is the BES-SVF there in that table, with 30 patients, and compared to an abdominal sacrocolpopexy, which is the gold standard abdominal approach to prolapse repairs. And it showed that for vault objective success, they both were similar at 1 year. So we still don't know what the durability is, but at the very least, we had some proof of clinical concept. On top of that, we also surveyed Canadian urogynecologists to see what would be a smallest clinically relevant difference to change surgical practice. So go from sutures to mesh arms, or just change practice. And from that survey, it turned out that approximately 14% would be the smallest clinically relevant difference to change practice. Based on that, it informed our next step, which was essentially to design our very own randomized controlled trial entitled COMET, which stands for Composite Outcomes Mesh versus Suture Techniques for Apical Prolapse, which we started in 2016, and we received CIHR funding for it. And essentially a multi-center Canadian trial, which is blinded for patients, not for surgeons, and it looks at the 2-year durability of these two procedures, mesh arms versus synthetic sacrospinous sutures. And a lot of people helped me with this. This is not a solo project for sure. Joel there was very instrumental, and so was Wei, And then there's Terry, whom you probably all know, Dr. Terry Lee, who has been my best friend for the past 5 years or so. We hold similar hours, sort of between 6 p.m. and 4 a.m. That's when we're most productive. And Christmas is right around the corner, so if you know Terry more than I do and you want to suggest a fantastic gift for him, please do let me know. And then the next most important person in my life is Nikki, sitting right there, who is our fantastic research coordinator with whom I could not do anything, really. So our primary objective with this trial was to compare mesh with sutures with a composite outcome measure at 2 years, and also a very long list of secondary objectives. So we're looking at pretty much everything you can possibly imagine: urinary bowel, prolapse symptoms, quality of life, new onset pain, body image, sexuality, global improvement, and on top of course, adverse events, reoperations, and last but not least, health utility. So a lot of REDCap data being collected. These are the surgeons who are involved, who have done this procedure, can do it, and are actually actively recruiting patients. So some of them are in Alberta, some of them are at McGill, and some of them are local here as well. And then we're trying to extend collaborations to other centers as well, so in Ontario and more surgeons in Alberta, as well as recently we've recruited a site in Brazil. And hopefully we'll be able to go train them perhaps in performing these mesh procedures, and they'll be able to contribute to our trial. The main reason we're stuck right now is, of course, with recruitment, because as you can imagine, going back to that slide on media frenzy, nobody wants to perform this procedure, nobody wants to have it. Although things have been looking up since the FDA removed all of the vaginal mesh off the market. Now really the only way to get this product is through my trial in Canada. So we get phone calls, hey, how can I get that mesh arm thing that you're doing? And then they get very, very, very unhappy when we tell them that it's only 50% chance they might get it. And so we also have goals of knowledge translation with this. It's a very good opportunity because we got funding to educate not just surgeons in how to perform these procedures better, but also the patients in what's prolapse, what are the different types of treatments that you can have. So we developed educational materials. We partnered up with a company who helped us develop an app where people can look at an iPad and look at their degree of prolapse and scroll through different, it's right here actually, it shows you essentially what the patients are seeing, and it describes it all in lay language, because we also partnered with a company who helped us develop the language and tone it down so that patients can understand. The other thing that we have in this trial is surgeon training that's with standard materials, so for sutures, mesh, and insertion devices, standard technique. So all of these surgeons that you saw in those pictures can perform all of these procedures in terms of suture suspensions and other prolapse repairs. The only thing is now they have to be trained in how to place these mesh arms in a safe way. So we developed an instructional video, as well as we offer training with the first 5 to 8 procedures and then ongoing if needed, as well as assistance with any complications that may develop if they do. This is the app. And this is our progress. So at the moment, so we have to recruit 358 women, and so we've only recruited 83. So recruitment goes on until 2021. At St. Paul's Hospital, we've got 47 women who signed consent, 20 at McGill, 9 in Alberta, 2 at McMaster, one of the late additions to our studies in terms of sites, and 5 in Langley. And some women have reached their 1-year mark. One woman has reached her 2-year mark. Everything is going well. There are no significant adverse events that are related directly to the procedure that we're doing. So it's going well. It's just we are having huge recruitment issues because of everything I've explained to you. So this is where we stand now. This is another picture of how I feel on a daily basis. This is me right here. But I know somewhere deep in my mind, subconsciously, slow and steady does win the race. So I think we will get there slowly and steadily. That's it.